All right, good afternoon. Thank you for giving me the opportunity to join you. I think we all started out with claims of our importance and bigness. So we have 46% of people have employer coverage. California is the sixth largest economy. Medicaid is the largest single payer of healthcare for people in the United States. More than 70 million children and adults are insured by Medicaid. The Medicaid and CHIP programs, CHIP is the Children's Health Insurance Program, Medicaid and CHIP programs can play a role in increasing access to obesity prevention and treatment services. As I think many of you probably know, Medicaid is a federal-state partnership that allows states flexibility to design programs to address state needs and reflect state priorities. As a result of that flexibility, there's variation across states in what obesity-related services, including obesity treatments, are covered for children and adults, as well as variation in the statutory authorities and regulations under which those services are defined, which is a mouthful. But I will take a few minutes to highlight some of the most common ways that states are choosing to cover obesity treatment services in their Medicaid and CHIP programs. And please understand that I am not going to provide an exhaustive list because that would put us all to sleep and get quite boring. So I will kind of hit the highlights and happy to try to answer questions afterwards. So in terms of coverage for children, through Medicaid's early and periodic screening, diagnostic, and treatment benefit, called EPSDT, also sometimes called the Medicaid benefit for children and adults, Medicaid-eligible children under age 21 are assured coverage of preventive and comprehensive health services. It is a very broad benefit. The EPSDT benefit includes screening, vision services, dental services, hearing services, and all services necessary to correct or improve, I think the statutory term is ameliorate, health conditions discovered through the screenings that are covered. So under the screening component of EPSDT for children, state Medicaid programs are responsible for assuring that children receive periodic physical examinations, including well visits, complete health and developmental histories, and health education. So screening for obesity would fall under the screening component, as would health education, providing an opportunity for a provider to discuss health concerns such as healthy weight and nutrition with a child and the parent, guardian, and family. Then any medical service or treatment determined to be medically necessary for a child that can be covered under Medicaid, such as nutritional assessments, counseling, medications, or surgery, would be available through the EPSDT benefit. With respect to adults, Medicaid programs differ even more from state to state on coverage of obesity-related services for adults, as you saw in the slides earlier today. Federal Medicaid law requires states to cover certain mandatory benefit categories, like hospital services. But states can choose to cover other optional benefit categories, such as diagnostic, screening, and preventive services. That's an optional service for adults enrolled in Medicaid. But a state, I don't know which is the right conjunction there, but a state can include obesity treatment services under a number of different benefit categories. So really, without getting any farther into the weeds, there are lots of different ways that obesity treatment services for adults can be covered under Medicaid. Some might be under those optional benefits for states, and some could fall under the required benefits for states, depending on how a state has structured its Medicaid state plan. Another newer state plan option for providing obesity treatment to both children and adults that I think is really important to highlight is the health home. States can create health homes to coordinate care for enrollees who have chronic conditions, including overweight and obesity. Health homes operate with a whole person philosophy where providers integrate and coordinate all primary, acute, and behavioral health care services, as well as long-term services and supports, maybe not as relevant in this context, to treat a whole person. So health home services include comprehensive care management, care coordination, health promotion, patient and family support, and referral to community and social support services. It's a broad range of services that can be covered through a health, or that have to be covered through a health home for states that elect to provide health homes. So health homes are for people in Medicaid who have 2 or more chronic conditions, or who have one chronic condition and are at risk for developing another, and a chronic condition includes overweight or obesity, or who have serious and persistent mental health conditions. So that's kind of another type of health home states choose to cover. You may know that Missouri has established many health homes for a number of different conditions in the state, and very recently added or made a change so that obesity qualifies as a standalone condition. So it doesn't have to be two chronic conditions. Someone with obesity could enroll in a health home with only that diagnosis, without an additional diagnosis. And so that's a new program in Missouri, and we're really looking forward to seeing what benefits and the outcomes and performance of those health homes. But Missouri has really been a leader in this arena, in the health homes arena. Another option for states that can improve access to obesity care and reduce costs is the Preventive Services Provider Rule, also a mouthful. But in 2014, CMS revised regulations to accurately reflect the statute that preventive services may be provided at state option by practitioners other than physicians or licensed practitioners, as long as a physician or licensed practitioner recommends the service. So it's kind of a technical option, but I think one that's important and advocates have been very interested in, for expanding the range of providers or individuals who can provide services, preventive services, which can be delivered to people with, who are overweight or with obesity, and potentially lower costs, because those providers may be less costly but very, very effective, so more effective at times in actually providing the services that people need. So I've just described some of the key Medicaid authorities that states can consider when defining or designing an obesity treatment benefit. It's not a full list of the possibilities by any stretch. And if a state wants to make changes to the obesity services that are provided in their Medicaid and CHIP program, they need to consider their state plan, their state context and priorities, and work with CMS to identify the best authorities under which to do it. It does and will continue to look different from state to state. But very importantly, and others have alluded to this, coverage of services does not automatically lead to utilization of them or imply a delivery of quality of care. There are many ways states can increase delivery and quality of obesity services, treatment services. Here are some of the things to consider when promoting a high quality care and impact. States should consider how to work with their Medicaid managed care organizations, their health plans, as partners. In particular, managed care organizations conduct performance improvement projects as part of their Medicaid contracts. So states could specify obesity prevention or obesity treatment as part of a performance improvement project to really have their managed care plans focus on that issue and improving delivery of care and testing out potentially innovative approaches to doing that. Many states have pay-for-performance arrangements built into their managed care contracts, and states can consider identifying metrics related to obesity care to include in their pay-for-performance measure set. And I know there's a lot of really important work underway right now on identifying useful metrics for the treatment of obesity. Which brings me, of course, to CMS's core sets of measures for children and adults enrolled in Medicaid and CHIP. Both of our core sets include of quality measures include a measure for BMI assessment. While I am well aware that it is a process measure with many limitations, we do encourage states to consider including it as part of a set of metrics that they collect and use to drive improvement for the quality of care delivered in their state. There are also adult core set measures for screening and managing diabetes, as well as managing blood pressure, so some of the common comorbid conditions might be a part of that set. Beneficiary and provider outreach is critical to improving delivery of care, as we've been hearing all day, particularly the behavioral interventions and chronic disease management interventions and services, such as those to treat obesity. In 2015, we released a set of free and customizable materials to help states promote their preventive services called Living Well. There are posters and fact sheets and an image library that can be adapted to states' needs and co-branded with the logos that state residents recognize. You can go to Medicaid.gov and type in Living Well to find those materials. And on a final note, collaboration across state agencies and with other public health partners is essential to making progress really on any chronic disease prevention and management goal. There's been some connection and talk today about all the attention to diabetes prevention and management right now. Many different organizations and states are working together on that issue from different angles and making some progress. And while I understand it is a different issue, I think there may be effective ways to link some of the momentum and efforts around diabetes prevention and management with obesity treatment to have a greater impact. So to wrap up, 4 things. There's a lot of flexibility in how state Medicaid agencies choose to cover and report on obesity prevention and treatment services. We have found that covering a benefit is not enough. For a benefit to have an impact, it needs to be promoted to beneficiaries and providers. They need to understand what's covered and how to get it. Third, we need measures in place to assess the quality and impact of those services on outcomes and on costs. And finally, collaboration across sectors is necessary to maximize the impact.